Now, in the second section, we will talk about some hematological abnormalities of pregnancy, or hematological abnormalities that can complicate the pregnant women. In this, we will talk about the sickle cell anemia, and then we will discuss about thalassemia and thrombocytopenia, and also about the bleeding and inherited coagulation disorders that can complicate the pregnancy. So first, let's talk about sickle cell anemia. Anemia is a condition in which there is a low level of hemoglobin or decreased red blood cells. Red blood cells have hemoglobin, which gives color to the red blood cell. And hemoglobin is a substance that carry oxygen to different parts of the body. So hemoglobin is less in anemia but in sickle cell anemia, it's a condition in which the shape of the red blood cells is affected. Instead of biconcave disc, which is the normal shape of the red blood cell, the cells are sickle shape and they have sickling of the shape. So as a result of this abnormality in the shape of the red blood cells, they can break easily, and they can cause blockage, and they cannot flow easily. So all these complications can cause anemia because of the destruction and decrease number of red blood cells, and in return decrease hemoglobin level. So sickle cell anemia. What are the implications of sickle cell anemia? Implications of pregnancy on sickle cell anemia or disease. So first, nausea and vomiting, anemia and infection increases. So if the patient has sickle cell anemia and she gets pregnant, the complications that can occur or the effects of pregnancy on the disease will be there is increased in anemia, and there is increased in infection, and increased frequency of crisis, sickle cell crisis, are associated with pregnancy. The effects of sickle cell on pregnancy are women with sickle cell trait generally do well in pregnancy. Increased fetal risk of miscarriage, preterm birth, intrauterine growth restriction, and perinatal mortality. These are the complications that can occur in sickle cell anemia, but usually it's well tolerated with sickle cell trait. But if complications present, usually they are intrauterine growth restriction, preterm delivery, perinatal mortality rates are high. So all these complications can occur as a result of sickle cell anemia during pregnancy. Management of sickle cell crisis in pregnancy. These are the shapes of the cell: normal cell and sickle cells. Management, prompt treatment. Adequate hydration is important because of serious hemolysis or destruction of the red blood cells. It's important that hydration should be enough that prevents these sickle cell crisis. Oxygen should be given to the patient. Analgesia, its crises are painful, patients have pain, they complain of pain, so analgesia to relieve that pain should be given. Screen for infection, urinary tract or respiratory tract infection. Antibiotics should be given if there are any infections. Blood transfusions because of anemia, leukocyte depleted and phenotype specific. So it's leukocyte depleted. Leukocytes are white blood cells. We do not need white blood cells, so the blood transfusions should have the red blood cells. exchange transfusions are performed. So all these are the different management strategies for patients with sickle cell anemia or sickle cell crisis in pregnancy. Prophylaxis against thrombosis like heparin should be given, which is a blood thinner. Fetal monitoring for the assessment of fetal well-being is very important during the crisis. Thalassemia, another condition which I want to talk about is the thalassemia. Thalassemia is a condition which is associated with decreased production of alpha and beta globin chain of hemoglobin. Again, there is effective alpha and globa chain production, and this again lead to anemia, and this condition is known as thalassemia. Implications of pregnancy on thalassemia cause significant worsening of mild anemia seen in many women with thalassemia. So with pregnancy, there is increase in the level of anemia and it gets worse. What are the effects of disease on pregnancy? Risk of inheritance of thalassemia genes, and there should be partner testing and prenatal testing. So again, there is inheritance, risk of inheritance. So screening should be done, partner screening is important, and screening during the prenatal period or prenatal visits is recommended to try to avoid that chance or risk of inheritance. The other condition is thrombocytopenia. Cyto is for cell, thrombo is for the term used is for the platelets, thrombocytes. Thrombocytes are the platelets. These are the cells which help in the clotting of the blood. So penia is the term used for the decreased level. So whenever there is decreased level of platelets in the blood, the condition is known as thrombocytopenia, decreased level of the platelets. These are the normal platelets. These are the platelets. Here you see there are quite a few platelets, but here this is the condition in which there is low platelets. You can see only 1 or 2 platelets. In this you have lot. So decrease in the level of platelets or low platelet count is thrombocytopenia. Causes of thrombocytopenia in pregnancy. We have causes, idiopathic causes, in which we have increased consumption or destruction of platelets. If there is increased consumption or destruction, both conditions can cause decrease in the level of platelets. Autoimmune, if there is autoimmune disorder or destruction of platelets can cause thrombocytopenia. Antiphospholipid syndrome, preeclampsia, HELP syndrome. HELP syndrome is also associated with this last LP is for low platelet count. Disseminated intravascular coagulation, DIC. Thrombotic thrombocytopenic purpura. So thrombotic TTP, known as TTP, thrombotic thrombocytopenic purpura. And then hypersplenism is a condition in which the spleen is enlarged and there is decreased level of platelets because of excessive destruction. So all these are the conditions which can cause thrombocytopenia, idiopathic causes. Then we have the other cause of thrombocytopenia in which there is decreased production of platelets, and if there is sepsis or infection, blood infection, HIV infection can cause decreased production of platelets, and malignant marrow infiltration. So all these are the different conditions that can cause thrombocytopenia or decreased level of platelets. Platelets are the cells in the blood which help in blood clotting or coagulation. If there is bleeding and platelet level is low, there is no stoppage to the bleeding and patients keep on bleeding. So that's the function of platelets. Differential diagnosis of thrombocytopenia in pregnancy. We have two mainly: isolated thrombocytopenia. One is pregnancy specific, then we have non-pregnancy specific. So differential diagnosis in pregnancy, we have isolated thrombocytopenia. There is no other abnormality associated with the blood or in the blood. It is only isolated thrombocytopenia. Usually it's gestational thrombocytopenia, 70 to 80%. In non-pregnant cases, it's usually primary idiopathic isolated thrombocytopenia, secondary isolated thrombocytopenia, drug-induced type 2b von Willebrand disease, and congenital thrombocytopenia. These are all the differential diagnoses in non-pregnancy cases and gestational thrombocytopenia in pregnancy. Then thrombocytopenia associated with systemic disorder. In pregnancy, usually they are associated with preeclampsia, HELLP syndrome, and acute fatty liver of pregnancy. So these are all the conditions in the pregnancy. In non-pregnancy, again, we have thrombotic thrombocytopenic purpura and hemolytic uremic syndrome, SLE, antiphospholipid syndrome, viral infections, nutritional deficiency, splenic sequestration, and thyroid disorders. So all these are the different differential diagnoses of thrombocytopenia in pregnancy, and then we compare that in the non-pregnancy conditions also. Bleeding disorders during pregnancy and delivery. Some other bleeding disorders are inherited, which are usually any vascular abnormalities, platelet disorders, coagulation disorders, and then we have acquired bleeding disorders in which we have thrombocytopenia, DIC, disseminated intravascular coagulation, acquired coagulation disorder, and then marrow disorders. So all these are the bleeding disorders during pregnancy and delivery. It can be inherited or congenital, or it can be acquired. Inherited is any vascular problems, platelet deformities, coagulation disorders, but the acquired are usually thrombocytopenia and marrow disorders and acquired coagulation disorders. So these are the two major classification of bleeding disorders: inherited and acquired. Inherited coagulation disorders, very common. We have hemophilia A, hemophilia B, von Willebrand's disease. These are inherited, present at birth, inherited from the parents, and usually these people, they have bleeding disorders, they bleed, and these bleeding disorders occur as a result of some bleeding clotting factor deficiency that help in the clotting of the blood, and when they are deficient, usually these people are more prone to bleed. So hemophilia A, B, and von Willebrand's disease. So that was all about some hematological diseases during pregnancy and what are the implications of these diseases during pregnancy. Thank you for watching sqadia.com.